So next is Dr. Joyita Das. Dr. Joyita, yeah.
Good morning, everybody, respected judges. Slides, please. It's not coming. Yes. Today I'll be discussing on delayed diagnosis of intraorbital foreign bodies, 6 years retrospective study on 18 cases. We all know that intraorbital foreign body is an important cause of ocular morbidity, and intraorbital foreign body is notorious for delayed presentation, and it is diagnosed after few days to weeks after initial injury. It occurs after a high velocity injury such as gunshot and workplace related injury. The management of intraorbital foreign body depends on the composition of the foreign body, location, visual potential of the eye, and presenting sign and symptoms. The diagnosis treatment of this poses a challenge for majority of the ophthalmologists. So, to analyze the clinical presentation, diagnosis, management strategies, and prognosis of delayed diagnosed cases of intraorbital foreign bodies treated over 6 years of period from 2016 April to March 2022, a better understanding and avoid delayed diagnosis of intraorbital foreign body, this study has been done. This is a retrospective interventional case series of 18 intraorbital foreign body cases treated by surgical exploration. The place of study is Disha Eye Hospital, tertiary care eye hospital in Kolkata over 6 years of period. Now come to the result. The mean average age was 33.55 years. Gender here male outnumbers female, most are male. The median presentation time after injury was 6.5 weeks. Minimum was 3 weeks and maximum was 54 weeks. The mean time lapse to diagnose the organic foreign body was 11.28 and the metallic foreign body was less, that is 6 weeks. The nature of foreign body are most common in my series was foreign, that is wood, metal followed by wood. And the mode of injury, the commonest mode of injury was workplace related injury followed by road traffic accident. Now come to the location of the foreign body. It is most common in superonasal location followed by inferomedial and superotemporal, next inferotemporal. The 55% of the mass of the foreign body was extraconal and 44% was intraconal. And among the presenting symptoms, dimness of vision was the most common, followed by pain, diplopia and swelling. This is the summary of the clinical profile and management outcome of the cases of my series. You can see the earliest case detected in 3 weeks period, and the most delayed was 54 weeks. And there is one interesting case was is a child of 12 years has an injury by mobile blast while playing with a mobile phone. And in imaging pattern, the CT scan was the most commonly done image, and outcome was it was most common, the better were outcome by 20 by 20 to more than 20 by 60 in most of the cases. Only 2 cases has no PL after management. So this is the first case I am showing. This is a 30-year-old gentleman presented with left eye injury 3 weeks ago while working in a factory. Chief complaint was persistent redness. His best corrected vision on 6/9. There was a flaccid with congestion in the ocular movement. There is left eye has a limited adduction, and in the opto scan you can see there is some streak of the traces of vitreous hemorrhage, localized retinal elevation, suspected perforation. And this is the CT scan. You can see there is a metal foreign body which is present near medial rectus muscle insertion. The management was orbital exploration followed by intraoperative barrage laser under general anesthesia, and this 17mm iron nail was retrieved. Patient went back to 6/6 vision after 6 months. This is another case of a fisherman who was attacked by a armed pirates while fishing 3 weeks ago. He presented with vision 6/12 and he has proptosis. Just finishing. Proptosis and some limitation of movement in abduction and superior temporal gauges. This is the foreign body we found, and after surgical exploration by transconjunctival orbitotomy, a 4mm pellet was recovered from the intraconal orbit abutting the lateral rectus. This is the case 3. This is a RTA.
Time is over.
Yes,
your
sir.
time is over. Please.
Yes, sir. This is just concluding.
Yeah, go to the conclusion.
Yes, sir. In this study, the organic foreign body are most often presented in the late cases. CT scan is the imaging of choice. And in my series, workplace-related injury as the leading cause of intraorbital foreign body. So use of protective device in the industrial workplace is highly recommended. Even if presented after a long period, it can be managed by appropriate surgical and medical intervention. Thank you.
See, it's called a delayed presentation of foreign body, but
Yes,
your
sir.
presentation cannot be delayed so much. You're only given 4 minutes. And first 50 seconds, I was just counting, you were on a slide which had no relevance to the topic. You are studying, it's a wonderful study, excellent study. You are supposed to present in 4 minutes. You should have come to the brass tack right from the word go. 50 seconds you spoke on general aspects of trauma, orbital trauma, which had no relevance to the actual study. You could have shown us all the cases, very well documented. So basically we still understand exactly what is important. See, there has to be some takeaway from your study. You have to enrich the existing literature. These are the things which went into the orbit, some people even did not know. And you have done MRI for many cases. How do you actually know that the foreign body is
In
not?
all cases, first we have done CT scan,
Okay.
and in those cases where it is excluded that there is no metallic component, or where there is confusion that there is no
That's
foreign
fine.
body,
That's
in those
okay.
cases I have done MRI.
Then okay. Then now can you tell us, like, was it the history taking that was important in suspecting the retained intraorbital foreign
This is
body,
very
or
important.
was it the clinical findings?
So both are important in
No.
our.
I don't want a theoretical answer. I want in your study what you extrapolate. See, every study has to give us some information. Okay. So in my experience, I would many a times retained intraorbital foreign bodies are silent outside. We
Yes.
may not have any telltale sign. It is not like you have a corneal entry point or a
Exactly,
iris
sir.
hole. Orbit, it can just go through the conjunctiva and it can get in the coats or get lost in the orbit.
Yes, sir.
So what was there? But the history sometimes, so in your case, what was the basically methodology? What are you trying to tell us from your study?
No. The delayed presentation sometimes, you're absolutely right. They are missed by the previous ophthalmology. They have already consulted. They have missed the thing, but then they presented with some issues like diplopia, or in many cases discharge and dimness of vision. In those cases, again we have taken. In dimness of vision, the causes are in 2-3 cases. There was some lamellar the placement of the one of the cases. Second cases I have shown the foreign body was in a lamellar fashion. So there is some localized corneal edema and effusion also there. Some vitreous hemorrhage also stresses of there. So this could be another cause. And in the no PL cases, the foreign body was placed exactly right in the apex, towards the apex, and that traumatic optic neuropathy already had happened. In 2 cases in my series.
And I saw that there was no B scan done in any case. In case of hazy median, you said there is some amount of suspected
So
detachment of vitreous hemorrhage.
No,
You
I have
should
not
have done.
presented the data here because I want to.
If you, since you are
yes,
talking about the investigation, you have to
Yes,
mention
yes.
about the B scan as well.
Yes, that's mistake from my side.
What Dr. Krishna Prasad has said is absolutely right. Most of the times it is a detailed history that gives you an index of suspicion. If your history is not detailed, that is the reason they are delayed. Not because of the symptoms coming late, it's because somebody has missed it and not asked the mechanism of injury, and the index of suspicion is not there, where you don't suspect a foreign body. So that is what you should have been highlighting.
Yes, sir.
The
Especially the children, they don't tell.
even in
such a-
adults,
Adult also in our scenario, they don't tell the history properly. They sometimes miss a trivial trauma, but actually that.
it can come in the most unexpected of cases. I have had, apart from this, I have had a case, a 55-year-old serving JCO in the army. He has never had a history of trauma. When I did his cataract surgery, there was a foreign body embedded inside the lens. And he never reported it with any trauma. Suppose you saw this on table and there was a foreign body inside. So it can be as minuscule foreign body can enter, and it might not present for years altogether. So similar is in the orbit.
Is there any situation where you would like to keep the foreign body without removing it? Have you gotten through that kind of situations?
There are some situations that is very small inert foreign body, like glass foreign body. We can also keep if it is in a position like in an extracorneal position, not damaging either the optic nerve or any retinal structure.
Metal?
Metal usually, aluminium, this inert metal you can take, but usually we remove that iron foreign body we should not keep. Some
you have-
inert metal, there are some like,
Have you treated
Aluminum.
gunshot injuries?
pardon ma'am?
Gunshot injuries with
Yes,
pellets?
one case I have gunshot injury, is pellet I have distributed, that is pirate injury in the Sundarbans area,
All
fishing.
All cases need removal or not?
Pardon?
All these cases to be removed or not to be left behind?
No,
What
this
is your take?
ideally it should be taken, okay, because that pellet has some lead component and it may have toxicity later on.
So, Dr. Krishna, what do you say? Because if there is a patient is asymptomatic, there is no problem whatsoever, and it is asymptomatic, probably we can leave it alone if it is behind the eyeball in the cone. So, what is your take, Dr. Krishna?
I mean, after thorough investigation, the patient absolutely asymptomatic. No evidence of inflammation or infection or any motility problem or a vision pertaining problems. It can be left because orbit is a Pandora's box. Even if trying to take it out, you can cause more damage.
More damage, yeah.
So primum non nocere. Firstly, do no harm. Just watch.
So
Okay, sir.
we
Thank you.
deal with gunshot and blast injuries a lot more as compared to the civil. What generally the prime thing that we follow is what the books teach us. If it is a blast injury and if it is a gunshot injury, because of the high temperatures, generally these are sterile. So you will not have an infective component ever. So then it's based on the tissue reaction. If you have no tissue reaction, we have patients with 20, 30 embedded foreign bodies in the cornea, which we don't remove for years altogether. Nothing happens. Nothing happens. So
Thank
you
you,
have to
thank
be judicious in the removal also.
Okay, sir, thank you.
So, can we